Okay. Yeah, morning, everyone. Today I'll just be talking about diagnostic evaluation and the management of male infertility. Yeah, this seems to be a broad topic, but I just tried to just summarize it so that it can fit into half an hour. What's happening? Am I going to be doing that same thing? Okay. Okay. So just an overview. If infertility is regarded as the failure of a couple to conceive in 12 months of regular intercourse. That is usually intercourse that is at least 3 times, at least 2 to 3 times a week, and they should not be on any contraception. And it's also regarded as failure to conceive in 6 months for a woman that is above 35 years of age. So we're looking at the female reproductive age here. So if they're above 35, then you may have to look at a lower threshold, 6 months, before you can start investigating them. Then they should not be on any contraception. Then when you investigate them or treat them, you should treat them as a couple. The couple should come as a unit, not to individualize the treatment. Yeah. And this is also supported by the current guidelines, which they investigate both partners simultaneously to categorize the cause of their infertility. Yeah. Then the epidemiology, there is what they call fecundability, which is the probability of getting pregnant in one menstrual cycle. They say it's about 25% in the first 4 months, and the 15% in the following 9 months. And it's about 85% will fall pregnant within 12 months. And it's about 40 to 50% of those who fail to fall pregnant in the first 12 months will do so in the next 12 months. So within 24 months, there's probably more than 80 to 90% have fallen pregnant. So this serves to emphasize that with infertility, you don't really have to rush to do extensive investigation, but sometimes you can just allow it to give it time. Most will actually conceive. They say of those that don't fall pregnant, like 50% in the first 6 months, it may turn out to be that some of them have some degree of infertility in the long run when you investigate them. And about plus or minus 40% is the male factor involved. In about 5 to 20%, the infertility is unexplained. And it's also somewhere around 30 to 40% the female factor involved. So cause of male infertility, there are various ways of classifying them. You can have pre-testicular, testicular, and post-testicular. Sometimes you can, this one I just used, this one where you use, one is the hormonal one when you use the gonadotropin releasing hormone, LH and FSH deficiency. So you have the congenital forms where you get things like Cowman syndrome, which is actually a gonadotropin releasing hormone deficiency. Usually it comes with hypo or anosmia, where they can't really have a sense of smell. And then it's also implicated in hemochromatosis, where there's iron overload, and also in some multi-organ genetic disorders like Prader-Willi, familial cerebellar ataxia. Then you also have acquired like pituitary and hypothalamic tumors. You can also get infiltrative processes like in the brain, like sarcoma, sarcoid, and also tuberculosis, and also histiocytosis, and also some fungal infections of affecting the brain that you end up with these hypothalamo-pituitary tumors. Then you also have history of trauma. People have had traumatic brain injuries, or some head trauma or surgery, and also radiation therapy. They may get also the acquired form. And also this one, also there are vascular problems that may come in the form of a previous infarction or vascular aneurysms of the brain. Then we get some systemic illnesses like people with chronic illnesses, and also some nutritional deficiencies, and also in obesity. Then you've got the primary gonadal disorders that will come in the form of the congenital ones, mostly like the Klinefelters, which is a 47XXY, which appears in 1 in about 500 to 700 births. And also hysteroform cryptorchidism. It's been implicated in infertility. Mostly they say when it's unilateral cryptorchidism and the other one is descended, usually the rates of infertility are almost the same compared to those ones who have got bilateral descended testes. But when you get to bilateral cryptorchidism, then the rates of infertility actually go up. And also, you have to take into consideration the time that orchidopexy was done. So usually when they are done, say below the age of 2, usually have preserved some germs or function of the testis, and usually have got a bit of desired fertility compared to orchidopexis or surgery that is done maybe towards teenager or after the age of 10 years, where you don't really get much desired fertility. Then you also have conditions like myotonic dystrophy, congenital anochia, varicocele, androgen also insensitivity, 5-alpha reductase deficiency, and also get Y chromosome deletions, which I'll just look also a bit into in the following pages. Then you've got also the acquired forms of your primary gonadal disorders, which may come in the people who have had mumps orchitis. Usually mumps orchitis, usually when it's bilateral, usually associated with some degree of infertility. Usually a unilateral one, you may get a contralateral one, which is fully functional, but in bilateral, then you get the effect on infertility. Then the granulomatous diseases like TB and leprosy, they also cause this acquired. You see in this sort of instances, you can get ductal obstruction from this granulomatous disease. Also epididymolysis, also drugs, the alkylating agents, also anti-androgens, cimetidine, ketoconazole. Also, these are anabolic steroids from people who abuse the BGM. And also you get radiation, ionizing radiation exposure. Also some environmental factors, also that will include also clothing, like tight clothing and stuff in warm environments. Then also previous trauma and also torsion and castration also implicated, and also systemic illnesses like chronic renal failure, cirrhosis, malnutrition, and also sickle cell have been implicated in the acquired. Then you have the disorders of sperm transport. This may come with also abnormalities of the vas difference. There may be bilateral obstruction, or maybe unilateral, maybe absence of the vas. It may also be previous ligation, also altered peristalsis, or maybe previous vasectomy. Then you also have factors like ejaculatory dysfunction that come like those with the spinal cord injuries or spinal cord disease. Some people have a previous sympathectomy, or some people some autonomic diseases, or those who have a erectile dysfunction, and also those who will be having retrograde ejaculation and also in premature ejaculation. I'll also touch a bit on the retrograde ejaculation in the following chapter. Then also people with cystic fibrosis, and also those who are born with the hypospadias, mostly the proximal ones, the implicated infertility, they will need surgical correction. So when you evaluate a male with infertility, you really want to take detailed history. If you want to be examining both concurrently, the male and the female should be assessed concurrently. And also you take into consideration developmental, like the testis descend, are the both testis descended, or is one undescended, or puberty, where was it reached in was the normal puberty reached, was the normal body hair distribution, that will just point to you to androgens. Also infections like history of previous swollen testes or swollen parotids that may point out to mumps in childhood, STIs, and also genitourinary infections, and also just pulmonary infections that may point also to these like fibrosis. Then you have chronic illnesses, like I have alluded, also visit of surgery. People have had inguinoscrotal surgery or maybe a previous inguinal hernia repair, or some people have previous retroperitoneal surgery, and also those who have previously had pelvic surgery, so they may come with incontinence. Then you've got drugs and environmental factors that involve like alcohol, smoking, the radiation, like anabolic steroids, the chemo, and also the antidepressants, antidepressant use. Then also sexual use. You want to look at this, the libido the same. Sometimes people tell you that they had libido in the past. Then currently now the libido is suddenly decreased. That may show hypoandrogenism, and also the frequency of sexual intercourse. That will also help you to assess is the couple having adequate intercourse to say they're infertile, and also prior fertility investigations or testing. You need also school performance. You may need to know are they really performing well in school. This may point out to clean filters with the really poor intellect. Then when you go home to do your physical exam for this, you need to relook at the general appearance, the body habitus, muscle bulk, also. Then you need to look at the enuclear proportions. This is when you look at their long bones, they usually have long bones, extra long bones. This is yeah, this is because of the failure of their epithelial plates to close because of lack of androgen. So when you do, you may find that their end-to-hand span from this one may be greater than their normal height. So this will be of much significance. Then you also look at their skin, like loss of pubic hair. There are some who had enough androgens, then eventually they get an insult and they have low androgens. So look at the hair distribution, axillary hair, and also facial hair. Look at the external genitalia, check for hypospadias. They'll go palpate and check for any bilateral or unilateral absent reverse difference. Check with the epididymis. Look also for features like for varicocele. Look also at the testicular sizes. You can use the Prada scale where they've got these beads with testis volumes. Also look at the breast. Then you go on to a further workup of semen analysis. When you do a semen analysis in these men with infertility, it should be at least 2 to 5 days of abstinence, and there should be 2 samples, abnormal samples, that are at least 1 to 2 weeks apart. So these are some of the variables according to the World Health Organization that you just look for, like a volume of ejaculate should be at least greater than 1.5 mils, and the pH should be alkaline, should be at least greater than 7.2, and the sperm concentration is more than 50 million per mil, and the total sperm count per ejaculate. This is different from sperm concentration. Within this total sperm count per ejaculate actually counts more than the sperm concentration. So the count per ejaculate should be more than 39 million. And also the morphology should be greater than 4% of the sperm should have normal morphology. And white blood cells, when you see leukocytes in the semen, they should not be more than 1 million per mil. Otherwise, they may warrant investigation, like doing sending to the semen for culture. Also look at the motility and also mixed antiglobulin reaction test. This is also done for anti-sperm antibodies, where you get sperm vibrating at one spot. Then you have also your biochemical variables that you use, like the total fructose, which is a seminal vesicle marker, should usually be greater than 13 micromoles in the ejaculate. You also look at zinc, which is coming from prostate, total acid phosphatase, which is a prostate ejaculate marker. Also total citrate, which is also a prostate marker, and then alpha glucosidase, which is also an epididymis marker, and also carnitine. This is just the other picture of this microscopic examination of a normal sperm. So when you look at some terminologies that are used, you know, you've got normospermia. These are when all semen parameters are normal. And when you talk of oligospermia, this is when you get same concentrations less than 15 mils. Then if it's mild to moderate, that's mild. For moderate, it's about 5 to 15 mils per mil. Then severe, less than 5 mils. Then azoospermia, that is absence of motor or a viable sperm. And astenospermia, then you get reduced sperm motility or slab. Then teratospermia is about abnormal morphology and shape. Then leucospermia, like I said, is just in leukocytes that are greater than 1 million in a mil of semen. So some specialized tests that you do for when investigating infertility, you have an endocrine test where you do your testosterone level, which you advocate to do in the morning, say before 10 o'clock in the morning, because of the diurnal production of testosterone. There are some cases where you may find a patient comes and their serum testosterone is low and their blood for testosterone was actually drawn at 3 p.m. in the afternoon. So you may have to really look at the timing for this testosterone before you can say the low testosterone. Also look at your follicle stimulating hormone. You know it's used and produced by the anterior pituitary, and also stimulating your Sertoli cells. That's for spermatogenesis. Also your luteinizing hormone, which works on your Leydig cells, and the dash is for testosterone production. Also look at prolactin, because when with hyperprolactinemia, they've got hypogonadotropic hypogonadism. Then also look at inhibin, which works also when it says the negative feedback on the pituitary hypothalamus axis. Just look also for sperm function tests. There are specialized tests that can be done. You have computer-aided sperm analysis. You've got also these various tests like for the acrosome reaction. You have also chromatin integrity, and you also do DNA fragmentation tests. For genetic testing that you want to do, you can offer men with non-obstructive azoospermia. You should offer them genetic testing. If they've got an obstructive cause of the azoospermia, usually it's going to need, unless if the obstruction is probably bilateral, congenital absence of vas deferens, or if there's clinical suspicion of a genetic abnormality, then they may offer genetic testing. Then also offer in cases of cystic fibrosis, conducted regulator. You can also do sex chromosome and also somatic mutations. And you can also look for Y chromosome microdeletions, and also look at androgen receptor, either hypoactivity, so that may point to insensitivity. They do the DNA fragmentation test. You actually find sperm DNA damage, which may be single strand or double strand DNA damages, which may be as a result of varicocele, which may be a result of chronic infection or lifestyle factors, like I've mentioned, or cancer, and also in cases where it's implicated due to increased oxidative stress with the increased reactive oxygen species. Then also indications for DNA fragmentation tests. You want to do in those cases where you're investigating for an unexplained infertility, or those with recurrent pregnancy loss, or those who have assisted reproductive technique failures, and also as the prognostic information for those who have failed at. So the DNA fragmentation index is usually, if it's greater than 25% or slightly above 25%, they are usually coupled with reduced pregnancy risk. Above 50% is associated with the poor outcomes, especially in vitro fertilization. Then in these cases, you have to consider using testicular sperms in high DNA fragmentation index. Management usually start with your lifestyle modifications. You have to do seasonal smoking, loose underwears and stuff. also stop smoking and alcohol, weight loss, and also exercise, increase exercise, also stress management, and also avoiding hot baths and these restrictive garments. And when you talk of Y chromosome microdeletions, they have a high frequency in asymptomatic patients, usually 8 to 12%. You get like microdeletions, Y chromosome in about 3 to 7% in those who are oligospermic. Then the deletions are rare with a sperm count greater than 5 million per mil. If the sperm count is below that 5 mil per mil, you may be warranted to also do this Y chromosome microdeletion because there may be a high incidence of these genetic anomalies. And when you look at the microdeletions, there's the asymptomatic factor A, there's factor B and factor C, but the asymptomatic factor C is the most common one, found in about 65 to 70%. The A, B, or A, B plus C is actually found in about 3%. And in the asymptomatic factor C, when you do sperm retrieval, you actually find sperm in about 50 to 75% of those in the C category, but in the other one, you rarely find sperm. So if you've done your Y chromosome microdeletions and you see their microdeletions are not the C type, the asymptomatic C type, then it's not warranted to go ahead and do your sperm extraction. You can just stop there, but for the C type, you can do sperm extraction. So that's the wake up for the male with infertility. So like if you just go down the nomogram, you need to look if they had a year or failure to conceive with regular intercourse, or at least the female partner is greater than 35 years, where you use 6 months. If it's that at the post-vasectomy, if yes, then you need to take them for counseling and post-vasectomy fertility options. If not, then you have at least one abnormal semen analysis. If it's a yes, then you complete the male evaluation with history and physical exam. If they are asymptomatic, then you have to categorize the azoospermia, do your FSH and the other hormone to see if is there some persistence at the testis level. If you see there is obstructive, usually do the genetic testing for congenital cases of obstruction. If it's non-obstructive, you need to do genetic testing, karyotyping, and also the Y chromosome microdeletions. And there's options for micro testing and also intracytoplasmic sperm injections. Then in those that you are oligospermic and they've got initial hormone evaluation is done and it's normal, then they will not need any further evaluation. This is just an overview of the hypothalamus-pituitary gonadal axis, where you see your hypothalamus and your anterior pituitary, so you see your hormones. Then you get your LH and FSH working on the axis. Then you get your negative feedback from inhibin and also from the testosterone itself. This will work in future when you use hormonal treatments for those non-obstructive azoospermia. This is just not a clear diagram. Then if you look at the medical management of your non-obstructive azoospermia, if you have seen this, just talks about if you look at the testosterone estrogen ratios, where you see they've got either a low testosterone and also a low testosterone estrogen ratio, where this may benefit from an aromatase inhibitors, and those with say a normal testosterone and also slightly high, greater than 10 testosterone estrogen ratio, who may benefit from HCG and HCG use. So our treatment options, if you have varicocele, some authors who, if you go to Campbell, to advocate for varicocelectomy, especially in the higher grades, grade 3 and some in the grade 2. There's always improvement in sperm parameters in most cases of about 30 to 60% improvement in the spermiogram parameters. Most of them are like stress related. Then some authors will advocate for not doing varicocelectomy, say if there is in older patients and in those that have a female factor, that they will eventually need either intrasite or sperm extraction and probably intrasite or plasmic sperm injection. So they say there's no need to do a varicocelectomy in that case if you're then going to do your ICSI, I mean. In those cases with the retrograde ejaculation, you can use an alpha-1 agonist like ephedrine and also imipramine, the side effect that you are using. But when we are faced with a patient with retrograde ejaculation, you suspect to have retrograde ejaculation, you take the post-coital urine sample. That's the one. If you find like sperm which are 10 to 15 per high power field, then it confirms your retrograde ejaculation. And if you want to retrieve this sperm for use either in intracytoplasmic injection or in vitro fertilization, what you need to do, you need to prep these patients with sodium bicarbonate so that their semen is alkalinized. Then when you take the post-coital urine sample, you collect, then you centrifuge it for about 10 minutes with around 1,600 rotation, gentle centrifuge at 1,600 rotations per minute. Then you can extract your sperm, then you can use it, do a sperm washout and use it for as assisted techniques. In those with sperm antibodies, like if done your MAR test and it's really positive, they've got antibodies against their own semen. In these cases, you may use prednisolone about 40 to 80 milligrams per day for about a period of 6 months. The side effects are a bit okay from the steroids. So most people don't really go for this route. Some may just go for assisted production with intracytoplasmic injection. If you see leukocytospermia, there is a leukocytes in the sperm, like we said, greater than 1 million. Then you send it for culture. I mean, some advocate for starting on empiric antibiotics. Although in some studies that have been done, in most cases, you may not culture any bacteria. So in cases where they have a hyperprolactinemia, either from an adenoma or something, if it's drug-related or secondary to a side effect of a drug, you stop the offending drugs. If it's adenoma, then you may treat, you can use of bromocriptine or cabergoline. So you have got to look at your hormonal options for treatment. There is there's use of aromatase inhibitors. So this decrease estrogen production. So hence also reduce negative feedback. You know, testosterone is converted by your aromatase to estradiol, and the estradiol actually has negative feedback on the hypothalamus-pituitary axis. So the negative feedback will lead to reduction in FSH and LH. So if you use aromatase inhibitors, so you prevent the conversion of testosterone to estrogen, so you end up having a bit higher levels of your LH and FSH. Then the use of clomiphene citrate is actually used to block negative feedback also from the estradiol, and hence also increases your FSH and your LH. Then if you talk of human chorionic gonadotropin, is been used, it acts similarly like luteinizing hormone, only that LH has got a very short half-life. So when you use the human chorionic gonadotropin, it actually stimulates the gestational and also spermatogenesis in the hypopituitarism, mostly seen after normal puberty. Then we have your selective estrogen receptor modulators. These they block the hypothalamic estrogen receptors. Hence, they actually stimulate your gonadotropin releasing hormone and also your production of your pituitary gonadotropins, which are your LH and FSH. Well, go to your obstructive spermia. Mostly it may be proximal, probably maybe from either progenitor absence of mass which may be bilateral, which may point to like cystic fibrosis. If it's unilateral, usually it doesn't point to cystic fibrosis, but in those we've got a unilateral congenital absence of a vas, you need to do a ultrasound scan, renal ultrasound, because from embryology, they may have a concurrent renal abnormality with them. So when you look at the abstracting of systemia, they usually have normal testicular volumes. They normally have a normal testosterone, LH, and FSH. They probably may have an absent vas, either bilateral or unilateral, or low fructose. And also, when you do a transrectal ultrasound, you may see dilated seminal vesicles. So your management of your obstructive systemia, if there's proximal obstruction, they're usually managed by vasostomy or vasoepididmostomy. Vasostomy usually may have done a vasography where you may use contrast or dye. Then if not at the point of obstruction, you may end up resecting that and doing end-to-end anastomosis. That is the vasostomy. So sometimes the obstruction may be somewhere at the level of the around the epididymis, more proximal. You may end up doing a vasostomy where you anastomose the vas preference to the seminal, to the epididymis. Then for your distal obstruction, usually occurs at the level of the ejaculatory ducts. Usually your semen volumes are less, usually less than 1.5 mils. And the pH is usually acidic, less than 7.2. Management, you can do your transurethral resection of the ejaculatory ducts. You can do it with the dye-assisted, where you can inject like methylene blue in the seminal vesicle. So when you do your resection of the ejaculatory ducts, you will see the blue coming out. And also in midline intraprostatic cysts, you can do cyst incisions or unroofing or aspirations. And also you can, at the same time, you can do a trust-guided aspiration of the seminal fluid for assisted reproductive techniques. So some sperm retrieval techniques, you can do PESA, which is your percutaneous epidural sperm aspiration with office procedure. You should just aspirate another local and you just put a needle into the epididymis and you aspirate sperm, usually for obstructive azoospermia. And your MESA, your micro epididymal sperm aspiration. And also you can do your testicular sperm aspiration, which is your TESA, usually for a failed PESA or congenital absence of the vas. Or you can do your TESA, which is testicular sperm extraction, usually for non-obstructive azoospermia or a failed PESA or obstructive azoospermia that has failed TESA. Or then you can do your micro-TIS, which is your microsurgical testicular sperm extraction done under GA. Is like an open technique. Then you use your microscope, you find the dilated seminal vesicles. That's where you target and you aspirate your sperm from there. Then you can use it for assisted procedures. These are just some of the pictures for assisted reproductive technologies. On the other one, you get your intrauterine insemination, where your retrieved sperm is just by syringe injected into the uterus at the time where it's planned ovulation. And then the other one is ISCI, where the sperm is injected directly into the cytoplasm of the ovum, and also you get your in vitro fertilization techniques. But I'll loss of time. Thank you.
Yeah, thanks a lot, Jimson, for a great overview of the topic. It's a very long one. I see you try and compress as much as possible. Any questions for Jemison, Dr. Chiswa, from anyone? Any comments? All right. I think in the interest of time, we'll close off the session. We'll see you guys in the next week. Thanks, Jemison. Eh? Yeah,